Thank you, sir. Good evening, sir, and good evening to all the dignitaries. My topic of research is effectiveness of e-health in public healthcare sector, an empirical study. I have done it from Institute of Business and Computer Studies, Shiksha Anusandhan University. So this is the plan of presentation: introduction, research gap, research problem, key variables in study, research questions, research objective, research hypothesis, proposed conceptual model, vision, mission, goal, and general objective, 10 E's of e-health, research design, review of literature, research methodology, research framework, model and theories followed, validity and reliability test of measurement scales, analysis and discussion related to objective 1 to 5, hypothesis testing through SCM, summary of findings, managerial implications, scope for future research, and bibliography. So basically, to start with, this everybody knows because everybody is more learned than me in this forum. E-health is the application of telecommunication and technology related to computer to deliver healthcare service to remote places. Alternatively, it refers to use of modern technology related to information, electronic and telecommunication to delivery of speedy healthcare services to needy people by transmission of electronic data to a higher center. So WHO definition says the cost-effective and secure use of information communication technology in support of health and health-related fields, including healthcare, health surveillance, health education, knowledge, and research. So this is the WHO definition. And why I've been motivated to do this research? Because this research finds out the service level of e-health entrepreneur in public health sector with the expectation level of patients. Secondly, it studies the relationship between the doctors and staff's expectation level and service level. There are many e-health entrepreneurs working in public health sector, out of which teleconsultation, DCL software, e-diagnosis, TechMed, e-registration, CDAC private limited are the prominent one and have observatory importance in the field. When I chose the topic in 2012 August, the e-health was recently launched in the public health sector, and e-health is an emerging area in India, basically in Orissa, which needs proper support to flourish. That's why this motivated me to research in this area to improve the status of the e-health entrepreneur, to make it beneficial for the public, and the research outcome will support the policy makers to take a decision in launching of new e-health entrepreneur, making it accessible to doctors and other staffs to accept e-health. Means this research outcome has made the administration, state administration, their view to positively towards the e-health entrepreneur and newcomers. So research problem statement: assessment of effectiveness of e-health in terms of quality service delivery, efficiency of system, cost compatibility, accessibility to different socioeconomic strata, and acceptance by physician and systems. So these are the key variables of study. I won't elaborate. Expectation level is EX, structure is ST, process is PR, or outcome is OU, and as for the entrepreneur name, it has been prefixed. Research questions is e-health is an extended modality to give the patient healthcare up to their satisfaction level in teleconsultation, e-diagnosis, and e-registration. Are the clinician accepting e-health as an alternative health practice and proficient in giving effective diagnosis and treatment? That is a question in everybody's mind, whether the clinicians are able to give the proper health practice to the patient or not. Is the support staff is properly equipped with the knowledge and expertise to give their service in e-health? So these are the research questions. So then comes the specific objective of the study: to assess the relationship of structure, process, outcome of e-diagnosis with the expectation level of patients, to the assess relationship of structure, process, outcome of e-registration with the expectation level of patients, to assess the relationship structure, process, outcome of teleconsultation with the expectation level of patients, to assess the relationship between service level of doctors and their expectation level, and to assess the service level of paramedical staff with their expectation level. So these are the 5 specific objectives. So the hypotheses are similar. The structure, process, outcome, whether it is positively affects expectation level of patients of e-diagnosis, e-registration and teleconsultation or not. Service level positively affects of expectation level of doctors and paramedical staffs or not. So these are the 5 hypotheses. So this is the proposed conceptual model. This is a vast model encompassing everything in it. So the model is quality of expectation, how it relates to quality of service. So the governance factor, it includes vision, mission, goal, objective, e-health grant strategies, reducing barriers, supporting staff expertise, whereas the entrepreneurial factors consist business implementation, HR policies, client relationship, and the patient factors, expectation level of patient, health service attribute, and the economic factor of the patients. And quality of service includes the 10 E's of e-health, the Gutenberg's 10 E's, empowerment of education of patient and physician, e-learning, extension of scope and new relation with the patient, e-consultation, enabling the information exchange and evidence-based practice, that is e-registration and e-diagnosis, efficiency of system and enhancing quality of care, that is effectiveness and efficiency, organizational efficiency, process efficiency, resource efficiency, and economic efficiency. And it also includes quality assurance framework, that is PDCA, Lean, 5S, and 6S. And ethics of e-health and equitability to the patient, that is social, economical, environmental, accessibility, acceptability, and availability. So this is the proposed conceptual model. Here the organizational factors includes IT infrastructure, IT knowledge, experience level of the staff, domain expertise, performance expectancy, effort expectancy, social influence, perceived usefulness and ease of use, attitude, behavioral intention of use. Entrepreneurial factors include business implementation, expectation from government, that is business initiation, business plan, business infrastructure, business strategy, business analysis, business impact, business risk. HR policies include HR hiring, HR satisfaction, client relationship, and then patient factors includes expectation level, health service attribute, health, structure, process, outcome, economic factor, governance factor, vision and mission, goal and objective, e-health grant strategy, stability, retrenchment, expansion, and combination, reducing barrier, business barriers, human barriers, financial barriers, and technology barriers. This is all about the proposed conceptual model. So as we all know, there is a NEHA, National E-Health Authority of India. It is vision, goal, and mission. The vision is attainment of high quality of health services for all Indians. Goal to ensure development and promotion of e-health. Mission that can be stated as to achieve the clinical decision by managing the patient effectively and efficiently. So the 10 is efficiency. The cost of healthcare is significantly reduced by increasing efficiency of healthcare. Enhancing quality, in addition to improving efficiency, the quality of care is also improved. Evidence-based practice of e-health enhances efficiency and effectiveness of calculative evaluation, not just by observation, by database. Empowerment of consumer and patients. The patients are empowered by making use of knowledge of electronic health records, helps them to avail patient-centered treatment and their choice of treatment to given them. Encouragement, the patient are encouraged to discuss their problems with physician, and new relationship is developed between them and consultant during their consultation. By sharing information and decision is made by informed choice. The informed choice is very important because it has a patient decision making capacity. It enhances the patient decision making capacity. Education, the education from internet and journals, webinars, online education is provided to physician staffs for their empowerment. Enabling, the healthcare professionals are enabled by exchange of information in a standardized way. Extending the reach of healthcare is extended beyond its scope in both sense, physically and concept wise, to obtain the healthcare from a professional online. Ethics, the ethical issues are to be taken care by consultants, such as a use of internet for practicing medical care, obtaining consent through the distance mode, privacy of patients, which are challenges in e-healthcare. Equity, the equity of healthcare should be achieved by e-health. The proper poor people, those who are illiterate and don't know use of computer and internet, can access e-health in an effective way. So research design, the samples are collected from Navrangpur DHS and Capital Hospital Bhubaneswar. The samples will be collected from e-health end user and patients and doctors and paramedics who will use e-health. Survey instrument tool and data collection, it will be done by questionnaire formulated by the researcher, and on teleconsultation of patient, e-diagnosis of patient, and e-registration of patient. The data will be obtained from primary and secondary source of database of e-health component of direct interview and telephonic interview will be done for collection of feedback and reliability and validity check of instrument tool. The survey instrument tool will be tested for reliability and validity, and the data will be tested for its statistical significance by chi-square test, F-test, and conceptual model will be tested for exploratory factor analysis and structural equation model test, which is a multivariate analysis. So these are the literature review objectives. I won't go in detail with the literature review. Just to review the literature on concept of e-health in general, to review the literature on potential for e-health, particularly in developing countries like India, to review the literatures on problems for implementation of e-health services, to review literature on intervention of government required in resolving the problems, to review the literatures related to healthcare informatics, to review the literatures related to quality in e-health and patient satisfaction. So these are the literatures. D. Rossi et al. He has given a description of implementation of e-health, which has become a challenge, which is sorted out by formulation of a multi-level policy, and long-term sustainability and integration of e-health innovation are adapted for the development of finance model for incorporation in public health sector. So these are the literatures. I'm crossing through the literatures. So these are the literature review which comprised government intervention in e-health in India, a model for healthcare accessibility at the bottom of pyramid, have elaborated the success of e-health is influenced by many critical factors. Data mining, clinical decision guidance, bioengineering, consultant, and consumer attitude are major critical factors. Are also health infrastructure plays an important role. Government policies also contributes not only to the technological factors but also the psychological factors, and also helps to create telecommunication infrastructure. So these are the literatures which issues related to quality. A marketer's approach to quality health service and patient satisfaction elaborated the quality is a cream of healthcare service. In last decade, India has much changes in business and industries. The quality of service and quality of product is being available in market met with the consumer demand and expectations. Sahi 2003. and the delivery of healthcare has been affected by a number of developments. There is a societal change in attitude of patient behavior is an important factor which sets an expectation level of patient from a hospital. And Thiru Murugan, he has elaborated that relationship between the perception of healthcare quality and patient satisfaction is empirically studied to find out the causal relationship between factors empirically by Al-Rubi and Al-Qaeda, and that trust and mediating patient satisfaction also taken into account. So then coming the research methodology, the research framework, it comprises research philosophy, research approaches, research strategy, choices, time horizon, data collection and analysis, research design and samples. So these are some models that has contributed to the research hypothesis. Model of customer expectation, how much the customer is expecting, whether there is ideal expectation or desires. When the ideal expectation and desire, then the expectation level is very high. Normative or should expectation, which is acceptable by the patient and by the doctor, and experience based norms, when they have some previous experiences, and on the previous experiences they have some kind of expectation. Acceptable expectation, that is the minimum level of expectation that is accepted from the doctor. Minimum tolerable expectations, that is low level of expectation and which is given by the doctor. Model of perceived service quality. Here, when your expectation level is very high, you are satisfied, and when there is low expectation, you are dissatisfied, then the perceived service quality is high. And when you're dissatisfied with high level of expectation, your perceived quality service quality level is low. So this is the core QoS versus QoE model. The QoS comprises structure, process, and outcome, which in relation the structure contributes to input, process contributes to key quality indicator, outcome contributes to key performance indicator, and the quality of expectation contributes to expectation level of patients, expectation level of doctors, and expectation level of staffs. Effectiveness versus efficiency. So these are the strategic goals, operational goals, and principal goals, which gives rise to operational results, strategic results, and principal results. So when there is effectiveness versus efficiency, so we need to gain more effectiveness rather than efficiency, because which is effective, that is efficient also, but which is efficient, that is not always effective. So model for managerial efficiency, these are the human relation model, open system model, and rational goal model, and internal process model. Human relation model, there is cohesion and moral. Open system model, there is flexibility and readiness, which ends with growth, resource acquisition. Rational goal model, the planning and goal setting, it ends with the productivity and efficiency. Internal process model means the information management and communication and stability, which ends in stability and control. So this is model for efficiency of organization. So this is a operational framework, social, economical, and political, how social and economical and political models influence the organizational efficiency. This is model for e-health literacy. This is the Lilly model. E-health literacy comprises with the traditional literacy, media literacy, information literacy, health literacy, computer literacy, and science literacy. Model of equity for social sustainability. How can the e-health will be sustainable in a rural area when we are implementing a e-health? So basically that should be sustainable, that should be bearable, equitable, and viable. and it comprises the social aspect, economic aspect, and environmental aspect of the patient. Model for equity, the e-health should be accessible, that should be available, easily available, that should be acceptable by the patients. So there are three theories which influences the e-health. Theory influencing e-health, that is technology acceptance model. When we are coming through the TAM model, the perceived usefulness, that is use, and perceived ease of use, that contributes to attitude towards using the e-health, and perceived usefulness is also contributes to behavioral intention to use e-health, and attitude also contributes to behavioral intention of use of e-health, and that gives rise to actual system use. Then theory of reason action, your behavioral beliefs, normative beliefs, and control beliefs contribute to attitude towards behavior, subjective norms, perceived behavioral control, and this gives rise to intention, and the intention gives rise to behavior. And your perceived behavioral control also gives rise to intention and behavior to use the e-health. And theory of planned behavior, attitude, subjective norms, perceived behavioral control, that is intention and behavior, it contributes to intention and behavior. So then comes the research methodology. The research design is exploratory. Method of data collection, questionnaire survey, personal contact and approach, telephonic and mail survey. The sampling design is purposive, random sampling for choosing respondents. Sample size is 240 for each e-health entrepreneur, 50 doctors and 50 paramedical staff. And instrument, patient questionnaire 1 for TechMed, DCA and DCL, patient questionnaire 2 for CDAC, organizational questionnaire for doctors and paramedics, and tools for analysis, confirmatory literature survey for questionnaire designing, exploratory factor analysis, and SCM for data analysis. Respondent, patients of e-diagnosis, e-registration, and teleconsultation, doctors and paramedical staff. These are the respondents. So reliability of measurement scales, TechMed questionnaire that has 40 items. The Conval alpha is 0.968. DCL questionnaire, the items number 40. Conval alpha is 0.829. CDA questionnaire, the item number is 20. The Conval alpha is 0.926. Doctor questionnaire, the number of items are 10. Convex alpha is 0.917. Paramedical questionnaire, the number of items is 10. Convex alpha is 0.856. So validity of measurement cells, the KMO value for expectation level in TechMed questionnaire is 0.832. For structure 8.860. For process 0.835. Outcome 0.866. For DCL it is 0.704, 0.750, 0.726, 0.714. For CDAC questionnaire, the KMO value is, for expectation level is 0.742, 0.839, 0.706, 0.803. And for doctors, KMO value is 0.860, 0.745. So all the significance is 0.00, where that comes within the degree of freedom. So this is a socio-demographic data analysis of e-diagnosis, that is TechMed. So maximum, the average of TechMed is 3.42, whereas the standard deviation is 0.56, and average of gender is 1.51, and standard deviation is 0.50, and average of marital status is 1.03, and standard deviation is 0.18. Average of education level is 2.94, and the standard deviation is 0.99, and average of annual income is 2.94, and standard deviation is 0.99. So this is the descriptive statistics of e-diagnosis and TechMed. I'm overcoming this. A same approach of testing hypothesis of e-diagnosis. This is the SCM model of e-diagnosis. The description of SCM of e-diagnosis: all the parameter estimates are highly significant. In other words, all of them are highly significant. The interpretation of on the parameter estimates are straightforward. For example, expectation increases by 0.512 for each 1 unit increase in structure. Expectation increases by 0.581 for each 1 unit increase in process. Lastly, expectation increase by 0.444 for each 1 unit increase in outcome. So this is the analysis of SCM of e-diagnosis. So this is the model fit of SCM of e-diagnosis. The chi-square value is 134.423. The degree of freedom is 38. The chi-square significance is 0, that is less than 0.05. The CMI value is 3.5, that is less than 5 and close to 1. So that indicates a good fit. And GFI value is 0.910, that is close to 1. It indicates a perfect fit. AGFI is value bounded by 1 and not bounded by 0. It also a perfect fit. 0.924 is the CFI value, which is also a good fit. The TLI value lies with the 0 to 1, that is 0.929. That is also a good fit. RMNCA SCA value is 0.048, that is little lower to 0.05, and which is also a good fit. So hypothesis 1 is accepted. The structure affects expectation positively. The process affects expectation positively. The outcome affects expectation positively. The result H1A, H1B, and H1C is accepted in a positive manner. The result minimum was achieved. The chi-square is 134.423. Degrees of freedom is 38. Probability value is 0.000. So this is the socio-demographic data analysis of e-registration. The average is 3.51 for age. Standard deviation is 0.564. 1.52 is for gender. 0.501 is the standard deviation. 1 is for marital status, and 0.000 is the standard deviation. 2.92 is the education level. 1.009 is the standard deviation. 2.88 is the annual income, and 1.032 is the standard deviation. I'm crossing through the descriptive statistics. This is the SCM of e-registration. And this is the interpretation. Expectation increases by 0.602 for 1 unit increase in structure. Expectation increases by 0.009 for each 1 unit increase in process. Expectation level increases by 0.205 for each 1 unit of increase in outcome. So this is the model fit of SCM of e-registration. So all the CMI and GFI, GFI, CFI and TLI are good fit because they are nearer to 1. And the chi-square significance is 0.0444, which is less than 0.05. Chi-square value is 2.137 and degree of freedom is 2. The hypothesis 2 is accepted. The H2A structure affects expectation positively, process affects expectation positively, and outcome affects expectation positively. The result of hypothesis, the structure H2A, H2B, and H2C is accepted. The minimum was achieved. The chi-square 2.137 and degree of freedom is 2 and probability value is 0.044. Then the coming socio-demographic data of DCL patients. The average is 3.19 for age. Standard deviation is 0.841. For gender, it is 1.76 and 0.446 is the standard deviation. 1.27 is the average for marital status. 0.445 is the standard deviation. And 2.85 is the average of education. Standard deviation is 1.227 For annual income, this is 2.39 is the average and 1.259 is the standard deviation. I am crossing to the, this is the SCM model of DCL. Expectation increases by 2.771 for 1 unit increase in structure. Expectation increases by 1.071 for each 1 unit increase in process. Expectation decreases by 4.268 for each 1 unit decrease in increase in outcome. So this is the model fit. All are good fit, CMIN, JFI, CFI and TLI because they are close to 1. And chi-square value is 1.95, 195.642 and degree of freedom is 59. So the result of hypothesis is structure affects expectation positively. It is accepted. Process affects expectation positively. It is accepted. Outcome doesn't affect expectation positively. This is rejected. So 2 hypothesis has been accepted and 1 sub-hypothesis is rejected. The result of default model, chi-square is 195.642, degree of freedom is 59, probability value is 0.000, CMN value is 3.316. So this is the socio-demographic data analysis of doctors. So I'm crossing through it because time shortage. The descriptive statistics, the N value is 50. The mean is 4.60 and for the service level of doctor is 5.12. The standard deviation is 0.990, 0.824 is the standard deviation for service level of doctors. So testing of hypothesis through regression, SCM approach I could not apply SCM approach because the number of sample size was less. So the R value is 0.91 and the standard error of estimate is 0.274, adjusted R square is 0.795 and ANOVA is 24.236 and residual is 23.764. So description of test and acceptance of H4, larger values of R indicates stronger relationship, which is here 0.911. R squared is the proportion of variation in the dependent variable explained by regression model, which is here 0.829. The small values indicate the model doesn't fit the data well. Adjusted R square 0.795 attempts to correct R square to more closely reflect the goodness fit of the model in the population. Output for the regression 24.236 display the information about the variation accounted for the model. Output for the residual 23.764 displays the information about the variation that is not accounted for the model. And output for total 48 is the sum of information for regression and residual. If the significance value is the F statistics is smaller than say 0.05, then the independent variable do a good job explaining the variation in the dependent variable. In the above table, the estimated model is expectation level of doctors, that is 0.231 plus 0.8 plus 0.853 service level of doctors. The T statistics can help you determine the relative importance of each variable in the model. Here it is 6.997, which is above standard value 2, which reflects highly significant. If the service level increased by 1 unit, then the expectation level increased by 0.853 units, 85%. Hence, for the above three test, which is proved that the service level of doctors is positively affected by the expectation level and H4 is accepted. So this is the socio-demographic analysis of paramedical staff. I am crossing it. This is the descriptive statistics. Expectation level N is 50, mean is 5.06, standard deviation is 1.114. And service level of paramedical staff mean is 5.6 and standard deviation is 0.495. So the testing of hypothesis through regression, this is the R value 0.886 and the R square is 0.784 and the sum of square regression is 16.803 and the residual is 44.017, the total coming 60.820. So in the above table, the estimated model is expectation level of paramedical staff, that is minus 1.567 plus 1.183 service level of paramedical staff. If the service level increased by 1 unit, then the expectation level increased by 118.3 units, that is 118.3% by paramedical staff. So this is the summary. E-diagnosis, most of respondents were in the age group of 40 to 60 years, accounting for 51.3% of total. Gender ratio more or less 50% each. This signifies that the respondents are young and only 4.6% of sample respondents had high school education. It is interesting to know that 96.7% respondents are married and average monthly income of the respondent was 2.94, that is approx 5 to 10 lakhs. In e-registration, most of the respondents were in age group of 60 to 60 years, above 60 years, accounting 54.2% of the total. The gender ratio is 47.9 is to 52.1. This signifies that the respondents are both from young and old age group. 42.1% of sample respondents have above graduate education. It is interesting to know that 100% respondents were married and average monthly income of the respondents was 2.88. So this is the socio-demographic analysis of teleconsultation. Most of the respondents were in age group of 40 to 50 years, accounting for 45.8% of total, showing that there is a more middle age group. The female gender ratio is predominant here, almost 74.6%. And there are 82 respondents from each graduate group and postgraduate group showing high literacy, opting for teleconsultation. Even post-PG literacy are also responded in this type of e-health service. Almost 72.9% respondents were married, and in this group, more higher income group is prevalent, which is almost 27%, above 10 lakh. And doctors, most of the respondents were in the age group of 40 to 60 years, accounting for 64% of total. The gender ratio more of our female male doctor, accounting to 78%. 94% of the doctors are married. 82% of the doctors are post MBBS or PG qualification. 68% of doctors have income above 10 lakhs. And paramedical staff, most of the respondents were in age group of 40 to 60 years, accounting for 52% of the total. The gender ratio more for male paramedical personnel like male staff nurse, pharmacist, and LT. Then the TechMed reliability value 0.968, validity of construct 0.832, 0.860, 0.835, and 0.866. The recommended value is 0.5 to 0.7, which is accepted. The DCL reliability value is 0.829. Validity of construct is 0.704, 0.750, 0.726, 0.714. The recommended value is 0.5 to 0.7, which is accepted. The CDAC reliability value is 0.926, and the validity of construct is 0.742, 0.839, 0.706, and 0.803. The recommended value is 0.5 to 0.7, which is accepted. Doctors, the reliability value is 0.917. The validity construct is 0.860, which is again accepted. The paramedical reliability value is 0.856, 0.745, and recommended value is 0.52, 0.7, which is again accepted. The category mean, the TechMed age is 3.42, DCL 3.19, CDAC 3.51, doctor 3.08, paramedical 2.60, gender 1.51, 1.76, 1.52, 1.22, and 1.34 for DCL, CDAC, doctor, and paramedical. The marital status for TechMed and DCL and CDAC and doctor and para is 1.03, 1.27, 1.06, and 1.20 respectively. For education, the mean is 2.94, 2.85, 2.292, 4.82, and 1.20. For income group, 2.94, 2.39, 2.88, 4.64, and 2.26 is the mean. The standard deviation is for age 0.56 for TechMed, DCL, CDAC, and doctor and paramedical staff. The age is 0.56, 0.841, 0.564, 0.601, 0.571. And for gender, 0.50, 0.446, 0.501, 0.408, 418, 0.479. Marital status 0.18, 0.445, 0.000, 0.00, 0.240, and 0.404. And for education, that is 0.99, 1.227, 1.09, 1.009, and 0.388, 0.404. For income, 0.99, 1.259, 1.032, 0.536, 0.563, and 0.803. So the summary, the structure, process, and outcome of e-health, e-diagnosis entrepreneur positively affects the expectation level of patients. So H1 accepted. H2, the structure, process, outcome of e-health, e-registration entrepreneur positively affects the expectation level of patients. Hence, H2 is accepted. In H3, the structure and process of e-health teleconsultation entrepreneur positively affects the expectation level of patients, but the outcome doesn't affect positively the expectation level of patients. So S3 is partially accepted, S3C is rejected. S4, the service level of doctors positively affects the expectation level of doctors, hence H4 is accepted. And H5, the service level of paramedical staff positively affects the expectation level of staff, hence H5 is accepted. So the managerial implication, it is important that the public health sector managers have to work on the process and outcome of health system so that the e-health entrepreneur can give better service to patient. This study will help the government develop right kind of policies for this sector. The result would be much helpful to the policy makers in formulating guidelines for adopting proper e-health entrepreneur. This study will enable e-health entrepreneur to adopt innovations so that it can penetrate the system. The findings also would be helpful to the labor organization to think in positive way to maintain healthy atmosphere in the enterprise that ultimately helpful to sustain their work life. This study has an increased literacy level among doctors and staff, which will enable them to accept e-health as alternate modality. The government also can use in pandemic like corona for giving better service to patients using social distancing. The strategic implications, the grant strategy, portal strategy, and SBU and PP model, and contract model and outsourcing model. So the Telemedicine Society of India gazette formulation to support policy level issues like legal and ethical concern, online registration of physician by Telemedicine Society of India, online course for 3 years mandatory for practicing e-health by physicians. The course module is to be prepared by NIMAS and TSI. Documentation of treatment procedure has to be initiated by Health and Family Welfare Department. Mm, Telemedicine nodes has been increased. EISU has been introduced as an innovation. The HD video conferencing monitors are to be replaced by HD video conferencing monitors. The remuneration and IT technician enhanced to highly skilled workers remuneration. For AMC and operational support manpower are outsourced and fund provided, and thalassemia test and SPLC test also started by Health and Family Welfare Department. The limitation of study, the study investigated only on 3 types of e-health entrepreneur. The study was conducted only on patient factor and organizational factor depending on the availability of samples. The entrepreneurial and governance questionnaire could not be floated in the Orissa due to less sample size and ethical issues, which is also a further scope of research in this study. Reluctancy to give feedback by doctors and paramedical staff, reduced sample size for which SCM approach cannot be performed in the doctors and paramedical questionnaire, and population of this study is limited to specific group of patient and disease, and the sample size is small and limited to 240 only for each group of e-health due to non-availability of samples in teleconsultation and e-diagnosis patient. The study was only limited to 250 sample size, which could have been extended more to have significant and remarkable importance. It only considered patient and doctors and staff as sample respondent. Further work more would be conducted by comparing entrepreneur and government executive. The work was restricted to state of Odisha. Future work can be done on other states in India. Future study can be focused on the role of specific type disease type, specifically like rheumatoid arthritis, which is specially treated in teleconsultation in Odisha. And the study can be extended to compare e-health with normal health available in public health sector. The study can be done in implementation of e-health in pandemic like corona, where the social distancing is a major issue. The expected outcomes, test results of hypothesis assumed at the beginning of a study are presented critically. Here few suggestions are provided for better management and development of e-health sector in Odisha. And baseline model design can be utilized for other public health system in Odisha and outside Odisha. As this is an action research, the same research can be conducted every year to know the exact position of e-health entrepreneur service level in public health system. This thesis can be used as a guideline for both researchers and academicians. So this is all about this is bibliography. This is all about the research and the thesis. So coming back to the dignitaries, any questions?